mild to moderate asthma, something we don't talk about very much these days, so with the focus on severe asthma. But there are some things happening in the mild to moderate asthma space, and so that's what the focus is. And maybe you could ask some questions about mild to moderate asthma. What do you think about this? So the things that I wanted to cover were the developments in T2 biology have now made it into guidelines after very aggressive resistance for many years, but they now have made it into guidelines. There's been a major change in guidelines saying let's stop using short-acting beta agonists and use ICS, fast-acting, long-acting LABA. That's one thing. The second thing is considering dry powder inhalers. So short-acting beta agonists are delivered via pressurised beta dose inhalers. And stop nodding.
That's called being an enthusiastic participant.
And then some thoughts about the changes in implementation, particularly around digital technology coming into the asthma space. So Dr. Fricker has coloured in the future of asthma in this image, and you can see that the text is the main sort of endotypes of asthma, and at the moment we focus on the smooth muscle endotype and eosinophil or T2 inflammation. And we think a lot about tissue remodeling and mucus hypersecretion, but don't yet have well-established therapies for those two types. But we do have well-established therapies for smooth muscle and T2 inflammation. And then the biology's been worked out with the specific cytokines in the T2 pathway, what their target is, and then now we have clinically accessible biomarkers. So this is what's driven its uptake in the clinical setting. But we can measure these things and use them in clinical decision making. And there's this really nice concept that Simon Couillard has put together of the bomb and magnet. So who's heard of the bomb and magnet idea? Are you the bomb or the magnet? Always magnet. Always magnet. I would have thought of the bomb. The concept is you need two signals to cause bad asthmatic airways. It's worth looking this up as a way of communicating T2 biology and also the heterogeneity of within T2 biology. So COUILLIARD is the Simon Couillard. So pheno is the magnet that drags the eosinophil to the airway, and the eosinophil is the bomb that explodes and causes badness in the airway. And it's in the clinic you see the relevance of this with the different monoclonals that are used. So when we use an anti-IL-5 monoclonal, we drop blood eosinophil counts, but there may not be any effect on pheno, for example. Whereas when you use an anti-IL-13 monoclonal such as dupilumab, you drop pheno, but you may have no effect on EOs, and in fact you may elevate the blood EOs because it's getting held up in the theories. That's getting held up in the bloodstream. So it's sort of, if you just focus on the clinical response, patients have a clinical response to both drugs. When we start measuring the biomarkers, differential responses, and it's explained by this following action. And there's probably more value in that going forward, more work to be done to identify other attributes of that theory. So these are the ways that you can look at this. You can use them to predict future risk, prognostic. You could use them to predict whether someone will respond to a treatment, which is called theranostic. And blood EOs have really good properties for both prognostic and theranostic. Pheno has some value as a theranostic. You can then use them to recognise disease, and this is the change that's happened, and that people who write guidelines are saying that we can use these markers to recognise the disease asthma, and that is their value as a diagnostic. Now, there are some nice little nuances that we'll probably get to as we talk about this, but that's the basic theory. So this is the example of blood EOs as a prognostic. The top two things show the higher EOs, the greater the risk of exacerbations, and the lower the risk that will achieve control of asthma. So it predicts what's the clinical course of asthma. And you could ask the question, what about combining biomarkers? So this is only just starting to be considered at a clinical level. And this is an analysis of the placebo arms of multiple clinical trials of T2 therapy. And if you just look at the this graph here, so it looks at the relationship on the x-axis of blood eosinophil count, on the y-axis with future attack rate. And on average, the higher the blood eosinophil, the greater your risk of future asthma attacks. Then it's split into three gradations of pheno. So in the clinic, most people just think of pheno as a level above 50 is the clinically relevant level. I think that's problematic, but anyway, that's where thinking is at the moment. But that's the red bar. And you can see once your EOs are above 300, and if your pheno is 50 or above, then you start getting the highest exacerbation risk. And this is the group, I don't know if you've heard the term hot from Ian Payboard. So this is the group that's hot. Blood EOs and pheno are both above the thresholds. The green line is normal pheno. So even though you can have an elevated eosinophil level, it doesn't give you a massive increase in exacerbations if your pheno is also normal. So that's an example of low magnet, high bomb. You've got bombs, but not a lot of magnets. And then the blue line, so why this is useful is people have not known what to do with the blue line. So the blue group are people who are abnormal, above 25, but not above 50, which is the clinically relevant cutoff. And it shows that if you can add the pheno and blood eosinophils to get clinically useful information in the blue line. So that's probably the most useful application of dual biomarker status.
Are they hot not?
I think they're hot.
Yeah. That looks like the red.
Green is hot not, or not hot. Maybe not hot.
So does it mean they should lower the clinical threshold for the pheno? Is that what you think? Lower.
I think you should. Well, I think you should. They're endless arguments. So what they are is an argument based on a cut point for what is a continuous relationship. So it's, the next slide sort of shows that as well. So those arguments are endless and they're won by the dominant personality at the time. So I think if what I would say is if this is your bread and butter, I think you should understand how to use both biomarkers. And probably the biggest thing is not to discount under 50.
Exactly.
Yeah.
Against off-ICS, effect placebo without off-ICS time.
No, they're on ICS.
I was just going to remind Peter that our pregnancy cut point that we developed was 29, so much closer to that. 25.
Yeah. And that was developed based on clinical risk.
Yeah.
As someone that knows their pheno, I know symptoms increase over 20.
So right.
Yeah.
So which category are you putting yourself in, Professor?
I'm hot.
Okay, there you go.
But I'm on treatment, so therefore I'm not hot.
Okay. And I think the other bit that's not talked about from this analysis is bronchodilator responsiveness, which is the other graph, which the more twitchy you are, the lower your risk of asthma attacks, which is very counterintuitive and is a real problem for the people who think that the muscle endotype is the only endotype of asthma. And they don't go into the
So do they superimpose?
well,
So just
I
one
don't know. It's a good question.
counteract the other?
That's been done.
Yeah.
You could. I'm sure. And maybe this is Simon Couillard's work.
Yeah.
So he may have done it.
Sorry, looked.
Yeah.
Yeah.
There is in the DREAM study in the online supplement, Ian adds this, and because they're all bloody O positive, he doesn't have pheno, I don't think, and it shows the same thing.
Yeah.
Okay, so I think this we've got T2 biomarkers in the clinic now, and we've got cut points that most people agree on, and they're good use, prognostic and theranostic. What is the actual eosinophil cut point is a point of contention. So the drug companies would like it to be lower, so more people can sell more product. This is a graph from the one of the vedolizumab clinical trials, and so you can use the placebo arm to look at the prognostic effect, which is what the other slide I showed you, and you use the active treatment arm to look at the theranostic effect and what should be the cutoff. And if you just look at the graphs over that side, because they reflect treatment with our currently used vedolizumab regime, so it's 8-weekly vedolizumab. So vedolizumab completely gets rid of blood eosinophils in the circulation. And you can see that the placebo and active treatment arms for exacerbations up the top and improvement in lung function very clearly diverge at 300 eosinophils and above. But it is a continuous effect. So you could, that's why the argument on it should be 150 gets put forward. And I don't have a big problem with that personally, as long as you recognise that it's continuous. But for a cut point that'll do in nearly all situations, I tell that it's real. So that brings in the guidelines. So after, I think the main person who was opposing this must have went on holidays or something. Anyway, the BTS produced this guideline. So this is a guideline. GINA is not a guideline. GINA never says it's a guideline. They say they're a management handbook. The National Asthma Council is not a guideline. They also are careful to say they're not a guideline. They're a guide management handbook. This is a guide. BTS produces guidelines. And what's different about this one is they've done systematic reviews and economic analyses looking at the place of biomarkers in treatment. And this, interestingly, this has now influenced both the Australian NAC and to the extent that it can, it's had an influence on GINA. So what's different about it? It's a guideline. It's evidence-based, and you get any further negative from that from those other documents. It includes T2 biomarkers, and it includes them in two places, at diagnosis and then as a theranostic or what to do after initial treatment. The other big change is putting Stimacort or motorol budesonide as preferred treatment for all levels of asthma. So for PRN, where you might have mild asthma, Ventolin only, they're now saying mild asthma, PRN, ICS for motorol. And it tackles the climate effect of inhalers head on, which has always been dodged up till now in guidelines. So this is their algorithm for diagnosis, and they put the T2 biomarkers up front. And this would have been heresy 10 years ago. They wouldn't appear at all, and its bronchial challenge would be the gold standard. So it's last. Interestingly, clinicians vote with their feet, so it's very rare to see patients have bronchial challenge for diagnosis of asthma in Australia. And it's usually used to rule out asthma for a while. But this is the pathway they recommend, and they've done an economic analysis to show that it's a cost-effective pathway. And they do blood eosinophils and FeNO as the T2 biomarkers. So in Australia, the people that write the guidelines have to do it their own way, so they remove blood eosinophils. They just want to have FeNO. This is how they tend to interpret the results. So if you have an abnormal T2 biomarker result and a history suggesting of asthma, then that's enough to confirm the diagnosis. And really, I think what they're saying is they're using the theranostic pattern. These people are likely to respond to ICS.
Why do you think Australia's not having? It sounds like a kind of honest, but it seems like a really big deal to know.
Yeah, it does.
Okay. Are we just leaving it there? Okay.
Yeah, I don't know. They give false reasons. So I wasn't part of the group. I don't know. But some of the stated reasons are false. You know, like we've got too much. We're different to the UK, which is really weird because. But we're different to the UK because we've got more allergy than the market now. So what I would say is, I think they're actually they're confused in their thinking by putting these as diagnostic markers. So they're really theranostic markers. But this isn't. I'm not going to raise that because it's such a good thing to get this into the guideline when it hasn't been possible. It's been acting consistent for so long.
Yeah,
So it's,
so it might change in time.
that's what,
It might change in time in Australia.
yeah, because I think what the guidelines, they now reflect the fact that people don't use measures of lung function in their routine practice in primary care. So the guidelines are coming up with an alternative to that.
Yeah.
Will they use pheno? So the Australian guidelines will tell you to use pheno. I don't think they will. I don't think average GPs can order a pheno. They won't know what to do.
Yeah.
But blood EOs, they'll be able to look at historically and say, that's what I think I'll start doing there once people start telling them. Anyway, this is how it fits in practice, and this fits in with our concept of where treatable traits should fit in the treatment paradigm. Once you recognise someone is likely to respond to therapy, you place them on ERN and/or maintenance, ICS for motor. And if asthma is not controlled on that, then you start again with clinical traits. And the two dominant traits the guideline highlights are T2 and airflow obstruction. But we would say this is where you come in and assess super traits. These two plus some other ones. So that's probably, they're quite big changes in mild asthma. So what are the benefits of this approach? So quite a lot of studies now, improvement in asthma symptoms, reduced exacerbations. There's believed to be a practical benefit in that you can go from having separate maintenance inhalers and relievers to just one inhaler. Formoterol is a fast-acting like salbutamol. And then the combination in the one inhaler seems to have an even better effect, which is not really yet explained. So I think this is good, but as a clinician, you do have to recognise a couple of things. It's not going to fix it all. So it actually reduces exacerbations by about 30%. So it's not stopping exacerbations. So there still has to be a pathway for what to do if you're not responding. Pizza time? Yeah. Okay, yes. Well, I think people should feel free to stand up and have pizzas.
I thought I'd model.
Model?
Leadership.
So the guidelines call this SMART, maintenance and reliever therapy. It was originally called SMART, and I'm advocating we go back to the original document for three reasons. One, I came up with it. Secondly, the PBS for this treatment specifies single maintenance or single budesonide, and it has the word single in there. So single is there. And there is, you can do MART with two inhalers, a reliever and a preventer, taped back to back. And every time you need the Ventolin, you flip it around and have the steroid. You think that's funny, but this is actually used in practice, and here's a nice trial showing the benefits of it.
It's a medical grade tape.
Yeah, so Clark is fairly what?
Medical grade.
Yeah. Clark is fairly what?
I made that.
She made this trial. But this was a trial. So ICS LABA combinations had a checkered history in the US. And so to look at this problem without access to those drugs, they did this trial, and they called it patient activated or reliever triggered inhaled glucocorticoid. So whenever you took your reliever, it switched it around and also took your steroid. It was done in black and Latino patients with moderate to severe asthma. And it was done in the US and Puerto Rico. And it's a positive study. So you can see, about a 15% reduction in exacerbations, risk of exacerbations. That's pretty good. And you're not changing anything other than using some sticky tape.
I can't believe sticky tape made it into the New England Journal of Medicine. It's innovative. Yeah.
And this is recent. I tell you what's happening to them over there. We've had since alive for a long time. They're struggling. Okay, so that's why this is smart, but it's not smart. So now this is switching gears to inhaler devices. And you can choose a prescription for a patient based on the drugs that are in it, the dose of the drugs, so it doesn't, there's a formulation convey the dose that you want, or give you that dose option, and the device, what's the device. And I'm just going to focus on the device. So, according to those guidelines, this is the question: what should you rate the choice of inhaler device? Correct inhaler technique. Because your valve is full, you put the hand up. Yes, it's the correct inhaler technique. Patient preference. One. Yeah.
It can't be me alone. Like, oh, right.
Not most of those correct answer. You could say all, who wants to say all the above?
No.
I don't know.
No.
Oh, poor doctors. They like to stick with what they like.
You're what?
She's throwing shade. Big on. Beliefs, let's do that.
Lowest environmental impact.
Yeah. They've got to be all considered together. Yeah.
So you're all, yeah, okay. Integrated dose count.
For the dose, yeah.
Yeah. So you know what that's about? That we, as clinicians and patients, how do you tell if your muffles?
History.
It's a real issue.
It's bright, makes you see
It's
sometimes
bright.
out, but it still does. Yeah. Yeah.
Why?
You could weigh it. Yeah, that's.
I know.
Doctors' beliefs.
Sorry, no.
So none of you support that, but as John says,
That's the reality.
that's the reality.
yeah.
This is a reality.
What?
I think it should come into it because it impacts the way in which you communicate with the patient.
Most people believe as well.
So your Chris Grange, for example, and you got a turbuhaler.
Yeah.
Or no, vernacular.
Yeah.
Then the patient might believe that that's the best drug for them because he doesn't breathe. So, I think that needs to be incorporated into the number of things.
Okay, so we've heard from the professor who is vacillating between hot and not hot. Yeah, lung deposition.
That's important. They all need to be.
So PMDIs with spacer, it's the highest lung deposition, 35%. DPIs, dry powder inhalers, about 20%. The differences. So
Well, there's no clinical evidence.
That's right, so this is what the BTS guidelines doesn't list doctors' belief or lung deposition as factors that need to be considered. Controversial, they do, the A, B and D, I think everyone would agree with. C is disputable, so I would say it's not considered in Australian practice. Do you agree with that? Yeah, whereas there was a big push in the UK to make this, in fact, to push everyone from pressurised inhaler over to the dry powder inhaler.
I think there's some success. If you look at the
But
science.
they went full on with it too,
Yeah.
they, you know, and then that upset others.
Yeah. And that was driven not by clinical efficacy, but by the environmental stuff. So this is the postdoc who did the work that discovered the hole in the ozone layer that got worse with CFCs. And they proposed this as a contributing factor in 1974. And 4 years later, they were able to get products banned that they said were contributing. That's high impact, I would say. Yeah, but there was an exception, and the exception was asthma pumps. And it's all been an exception. Every year it's an exception. You cannot use this except in asthma pumps.
What year did CFCs get phased out? That was 95?
Yes.
So the Montreal Agreement was 1988, and then the CFCs were the last to get phased out, I think in 97.
97.
I think,
And they were replaced with less ozone depleting. But they're not zero ozone depleting,
No.
so there's now an active program to get rid of those, which we may see in clinical practice probably in 2 to 3 years. So, but in the interim, the push has been for dry powder inhalers, so this compares, this is a patient discussion guide for the BTS guideline that compares the environmental CO2 output of driving from Maitland to work, which is that one.
Yeah, I was gonna say.
Driving from Maitland.
Yeah.
Equivalent to a Bentley puffer.
Not being your flexitol.
Yeah, so that's going through 2 puffers a day would be going to work and going from work back home in terms of CO2 output. Versus the dry powder inhaler, which is quite less.
You know what should be on there is the CO2 emissions for hospitalisation.
Yeah, because if they don't
Put
use
it in
it.
context, because it would be off the scale.
Yeah,
And it kind of then, if it's a patient education thing, it would demonstrate to patients the impact of hospitalisation from the environment as well.
well, you guys can do that.
I missed your question, but if the dry powder inhalers only implicit on about 20% of it, the other one's like 35%. So to my basic mind, that means you're not getting as full effect of the medication. Like, are the health outcomes the same though?
There's no demonstration of superior health outcomes.
Okay,
And it's probably because of the dose.
okay,
We're probably operating at the top flat part of the dose response.
yes, okay.
Which it's a little bit counterintuitive. You think we should see a health outcome.
Yeah.
So this is the push for dry powder inhalers, but dry powder inhalers have a bad name because people believe they're totally inflation flow dependent. Can't suck in hard enough, you don't get the drug. So this is your morning history lesson This is the first dry powder inhaler, 1968. It's in the Museum of Design in Plastics. And it's called the spin inhaler. Who's ever seen one of these? So how it works is you open it up, you put a capsule of the drug.
Yeah, I can hear the noise.
Put a capsule of the drug in, you close it, that pierces the capsule. You put it in your mouth, suck, inhale fast and strong. And can you see the cutaway? There's a little propeller.
Would they have made Intel like this in the 80s?
Yeah, this is
That's what I
Intel.
thought I'd
This
seen.
is the only product was in this, was Intel.
Yeah.
And yes, it was, yeah. What did you think?
I don't know, I just can still hear the noise of the spinning.
Yeah.
Yeah, they have modern day ones.
Oh, what?
They have modern day capsule ones where.
Yeah. And yeah, so the propeller spins around, creates turbulent flow and aerosolizes the powder from the capsule, and you inhale it. And life's bliss.
Sodium chromoglycate, right?
And so the guy, this is the guy that invented this, is an Armenian heritage, Roger Altunian. And this is there's some interesting things about Roger Altunian. So I don't know where to start.
Interesting slide.
Yeah, so his family they lived in Armenia, but because of political issues, and I don't know if you know the Armenian story, but it's pretty horrible. But anyway, they used to travel to the UK as a family and holiday in the Lake District, and they made friends with an author, Arthur Ransom, who wrote a book, and they appeared in the book. So he appears in one of Arthur Ransom's good books as a character. That's one thing about Roger Altunian. Second thing is he had bad asthma, and he would self-experiment. So there's a lot of work going on with guinea pig models of asthma, trying to find, because at the time, all they had was adrenaline and prednisone. A new drug came out which had all the benefits of prednisone without the side effects. That's how it was marketed, and that drug was dexamethasone. And so the reason it had no side effects is it hadn't been on the market long enough. So they was actively looking for new products, and they used the guinea pig model of asthma, and you had to do better than adrenaline. So he was involved in this and was trying them on himself. So that's one other interesting thing about him, self-experimentation. And one of the things that was being looked at was an extract from a herb that grew around the Mediterranean called Keller. Keller was the popular name. That's what it looks like. And the active ingredient was Kellan. And two drugs came out of that, chromoglycate and amiodarone, which is a cardiac drug. It'd be interesting. And amiodarone probably references the genus name of the plant. Anyway, they managed to, he tested chromoglycate. It was just, there's a really interesting T2 story, which we haven't got time for, but he put it in the, he worked out that it helped his asthma, and then came up with the idea of putting it in a dry powder inhaler whilst he was having a warm bath. And the connection was that he was, for 5 years in the Second World War, was a RAF pilot. You know, the British planes with the single propeller at the front. So the pilots would sit there and they looked through a propeller for hours and hours. So that was his job. He did it for 5 years, and he had a bath one day and made the connection between this might be a way of aerosolizing the drug. And it was, and so that's how the spin inhaler and the first preventer T2 treatment for asthma, inhaled therapy for asthma. And so this is the principles of dry powder inhalers, that you get the drug into the airstream by creating turbulent flow, and it's inhaled. And for a dry powder, the inhalation method is different for a puffer. So a puffer is slow and long, both pressurised inhaler is slow and long, whereas this is a fast and strong, fast and deep inhalation. And that leads to inertial impaction, if part of it's small enough, into the large bronchi and the bronchioles. And then the breath hold at the end of the inhalation allows for sedimentation, so you get an extra bit of deposition. So the inertial impaction and sedimentation are the two mechanisms by which the drug gets to the airways. And dispersion of dry powders depends on three things: the pressure drop at where the powder is being aerosolised, which is related to inspiratory flow and device resistance. So, true or false? There's only one correct answer here. Low resistance DPIs are the most effective, are the easiest to use, require the highest flow rates, have minimal variability in deposition. We'll keep going to James. I don't expect people to know the answer to this.
It's used to use, maybe.
Is it to use?
Oh, so
I used it for it.
Yes. The extra bits that goes to Harrow.
I was going to go for
So you would intuitively think a low resistance dry powder would give you the best chance of getting the stuff. But in fact, because of that equation, it's not the case. And the device resistance is actually a high resistance device, aerosolizes, creates more turbulent flow and aerosolizes the drug more easily. And this was not appreciated. Like, I didn't know about this till last year, for example. So we just thought dry powders, they're a problem, let's just leave them alone. And they're too flow rate dependent. And so in preparation for this talk, I studied all this background, stuff that I'd ignored for a long time, and came to grips with this counterintuitive situation. So Altoonian created a device that was low resistance, but it meant that everything was dependent on inspiratory flow. So everything all depended on inspiratory flow. So you had to have a high inspiratory flow. That's good for kids, but for older people and sick people, it's not easy. But people didn't know that. And so GSK, after Altoonian's device, they went off and tried to improve it and developed a rotahaler, which was even less resistance. It required, so Altoonian's required 120 litres per minute optimal flow rate. That's huge. And then the spinhaler, the rotahaler is 150. So both those devices have been discarded. And we now operate with medium to high resistance devices, which are much less dependent on inspiratory flow rate.
What do you mean by resistance?
So if you suck through the inhaler, you feel how big an effort, you perceive the effort you have to apply to generate airflow through the inhaler.
Okay, so it means you have to do it a lot if it's high resistance?
No.
So if you suck through a straw,
Yeah.
there's no resistance.
Sorry, you perceive increased effort when it's high resistance. Yes.
You perceive increased effort.
Hard.
But if you put Blu-Tack in a straw, Yeah, with a smaller hole.
Okay. That's high resistant.
Oh, okay.
And you would, intuitively, you'd think, okay, if I have to work harder to suck it in, I'm not going to get as much of the drug. But in fact, because of that relationship between those two factors, the flow rate you need is less if you have a high resistance device.
Yeah.
And that becomes important when you have people who have low flow rates. So kids, elderly, sick people. And so modern inhalers are not as flow rate dependent as, say, the spin inhaler was. And then the exception is the turbuhaler. So the reliever device, which has the best properties, is this one, the easy inhaler. Do you know this one?
Yeah, my daughter had that in Sweden. That's when they gave her.
Yeah, so this was designed in Sweden or Finland. It's from a Finnish company.
Mm.
So where it links to the environmental carbon debate is it's a dry powder, so it's less than driving from mainland. But it's that company who manufactured it made a commitment for it to be carbon neutral, so they offset the costs of that. So it's the only carbon neutral respiratory product that we have. And this is sort of just to go through how it works. So the drug reservoir, that's the drug reservoir. The spinning wheel is what you spin, and that's what creates the turbulent flow. And then there's side flow that comes in, and that spins the whole thing around. So you get turbulent flow and then a spiral airstream, and then that's what gives you small enough particles in the airstream that will then impact. And it's surprisingly tolerant to low flow rates. So this is the amount of drug delivered for high, middle and low flow rates, and surprisingly consistent. So this is a Bland-Altman plot of dose variability. And when you compare it to the turbuhaler, you can see it's a lot more variable. So that problem with the turbuhaler is why the turbuhaler is not registered in the US. That's part of the reason that the US has been so late to the party with ICS lava. And then the modern dry powders have fewer steps than the pressurised inhalers. So they have 3 steps: shake or some initial activation step, click, and then inhale. So what people often don't appreciate is the inhalation profile that you teach is different for a dry powder than it is for a pressurised inhaler. So the pressurised inhaler is slow and deep, slow and long, whereas the dry powder is fast and strong or fast and deep. And this is a graph where they've kept the time the same, but they've compared fast versus slow. And the solid line shows that you get more if you do fast from a dry powder than if you do slow. So I think these are the 2 modern devices that we have access to that meet these sort of things that we're talking about. They're dry powders, they're medium to high resistance, less flow rate dependent, and they cover the compounds that we can use. The other dry powder devices are not as sophisticated as these 2. What's Harrow's view?
Yeah, I've always liked the elliptic device for its ease of use and the dosing of that.
Yeah.
I'm not as familiar with the Finnish No, but and it's interesting, I didn't know that, like an MDI, it has all its doses in one just mixed big container, rather than like the lift device has individual blister capsules inside it.
Yeah,
And I like fluticasone furan. I think it's a really good steroid that's in the lift device.
yeah, so that's a separate issue.
Yeah, not the device, that's a drug issue.
Yeah. And the exception to this, is the turbulate, which they, if you pull the turbulate apart, you see a spirally thing, it's just called cyclone. And that, they designed that to require a minimum flow rate. So it is less, it has more of a flow rate dependence. And it's why I think paediatricians are not that happy with turbulate.
So do the easy halo get used very often?
Not in Australia. They've only just started marketing it in Australia like last year.
It's the last inhaler market.
And then they're not very
Threats coming around.
I don't think they're doing it, which is
That's a shame.
a shame.
That's what I was gonna say, like, when we asked for it, because my daughter had to go back to the other one,
Great.
to the pressurized one, it would be so much better if we could go back to that.
Well, you can't get started here.
So we just asked the doctor.
Yeah,
I think
but it'll be more than the doctor, because the chemist won't have it.
No.
So, and they can dispense not that long.
yeah, it's
So
generic.
you have to ask the doctor and the chemist.
And write the trade
Do you
name.
know a chemist in Newcastle that has it?
I don't.
Docs pharmacy,
Docs.
Docs.
Docs are pretty helpful.
No, the hospital pharmacy, wherever most of them is from.
Yeah.
Computer increase.
Every asthmatic in Newcastle turning up.
The Easy Handler also have a dry powder salbutamol.
Yeah.
And I think that's a big market driver in Europe.
That's what she had, was
The
the
salbutamol
in
preparation.
that, yeah.
In Australia, there's no non-MDI salbutamol preparation.
Oh, okay.
Are there
So
any
dumb.
groups of patients for whom this type of inspiratory action is just not possible or suitable?
Yeah, yeah, and so you sort of have to think, how do you put this into practice? And I think the guy who's been most helpful about educating us about this is Rani in the Brompton. And so if you ever get a chance to go to one of his talks on this, they're really informative. But what he says is you, if you are going to give the patient the choice, or if you want to make a decision yourself, you tell them about the 2-minute ablation techniques and ask them to demonstrate them to you. And that will uncover what the person can or cannot do. Yeah. So the alternative is to say, well, let's just do PMDI spacer. This is because it's the best deposition and you take away the coordination of breath and inhalation. And that is many clinicians or some clinicians say this is the only modality, that's what we should do. So let me ask you this question. If you are sitting next to a person with asthma right now, what have they got as their rescue medication? Who thinks they've got a PMDI and a spacer?
Uh,
I think you do.
Oh, maybe not the spacer.
Yeah, no,
I don't have a
PMDI.
Raquel.
I'm Dottie.
I don't use my space.
So yeah, so
You would for sure.
what my patients tell me is, yep, I use my PMDI and spacer all the time at home. And I say, show me what you've got in your bag. Oh, I've just got my PMDI.
Yeah.
So when they go out, they don't.
Yeah. Kelly gave me his. Yeah. I was going to say we've
And then the latest thing that's happened is some of the severe asthmatics on monoclonals who go into remission, they don't bother taking anything. And so I have to give a talk on this in a few weeks. I've been asking patients just exactly what have you got? And this one young woman said, well, I don't take anything. I don't take it at all. I said, well, what if you go out? Like you go out to a concert or a party and something like that. She said, oh, well, I take it. What I take depends on who I'm going with. And if I know I'm going with a friend who's an asthmatic, I don't bother.
But they might have thought
They might
she
think
was
the
gonna
same
bring
thing.
it.
Does that concern
terrible.
you quite a lot, that they'll be walking around with no medication? Or are you confident in their remission? Yeah.
It's risky. They're they're proven they're the most at risk group.
Yeah, so you don't have that much confidence in the map that they're not gonna.
Well, will it completely block the response to triggers? So this is what Frick is going to tell us in the future study.
Yeah, right.
So it's measured saline and hyperresponsiveness in people on maps. Oh, actually, yeah, the answer is too.
There is a decrease, but for sure, it works, but it's not. I would recommend that taking their medicine.
So if the airway hyperresponsiveness completely went away, you'd say, okay, we probably don't need any short-acting cardiac. So you two guys, does the airway hyperresponsiveness completely go away? How often?
Not in my experience,
Not
not
completely away.
but in some cases, yes, it does actually, yeah.
Sally Wenzel did a study on dupilumab and, trialing that and showed that the PD15 gets a lot larger, but it's still there, so yeah, just takes longer.
So were you saying that the ones that go into remission and they're going out going, I don't take it anymore? Does that mean like saying that they're in remission? Because I'm assuming the patient knows that is actually kind of risky then, because they're like, oh, right, the doctor said I'm in remission, I'm good, I don't have asthma.
No, that's not how it works.
No, it's not, okay.
Well, firstly, you make the assumption that the doctor says something, the person listens to something.
Yeah. Well, I listen to my doctor, okay. But I'm just wondering, like, if that's what they hear, they just go, oh, I'm all good then, I don't have to worry.
So that's
I'm
a
sure
good,
they can
good question. I'm not sure if it's coming out.
I think it's more the experience of being in remission rather than something saying to them, you're.
Yeah.
Okay.
Okay.
I haven't
So,
seen
yeah, so it gives them like a
for-
sense of security.
For a year, I haven't
Yeah.
did it anymore.
Yeah.
Yeah. More.
So what people say, they say, I don't feel like I have asthma anymore.
Yeah. Thank you.
So
Yes.
that's probably what leads on to that behaviour.
Yeah, it's kind of
But it is a risky behaviour.
I always wonder about whether these people were adherent to isoslavir because it helped with their symptoms. And that was driving their adherence, symptoms driving their adherence, and then we give them more antibiotics which relieve these symptoms, thus removing their impetus
Yeah,
to.
that'd be me.
I think that's most people, where they got some symptoms, and suddenly they don't have that driver anymore, so
Yeah.
psychologically, there's not this constant reminder.
Yeah,
Okay, asthma, 5, 4, 3, 2, 1.
that's great.
5 self-management skills. I just skipped all through that because I want to have a piece of pizza. 4 action plan elements. When to increase treatment, how to increase treatment, how long, when to for. 300 eosinophils, cut off. 2 steps to inhalation. Fast and strong for dry powder, slow and long for pressurised inhaler, and 1 inhaler. That's asthma today. Tomorrow or the future. So this is in a little snapshot is the SWIFT study showing that you take a treatment twice a year, you get good asthma control, including remission in some patients. So the future could be that that's what you do. You're on twice yearly biologic and you use your ICS formoterol for symptoms and triggers.
Yay. When can we get there?
Sounds good.
Definitely next year.
Okay.
possibly this year. Are you all right? End of discussion. So.